Welcome to Your Family's Health, the program that focuses on healthcare issues with unique and different modalities for taking charge of your health today. Experts talk weekly with our continuing roster of guests from around the country and right here in Nassau County to keep you up to date on the latest health issues and trends. Take care of your mind, body, and soul. Spend the next half hour with the voice of Nassau Community College, 90.3 WHPC, and get on the journey to better health.
Hello and welcome to Your Family's Health. This is Joan Buckley from the nursing department here at Nassau Community College. And today we're going to be talking about a type of cancer that really gets attention, but it's more important to learn all we can because you just never know if it's going to affect you or a family member. It's the third most common form of cancer, and we are talking about colorectal cancer. And to do this really effectively, we're talking to our guest today, Dr. Andrea Sursik. She's a medical oncologist at Memorial Sloan Kettering. So, Dr. Sursik, could you just, we're welcoming you to Your Family's Health on the voice of Nassau Community College 90.3 WHPC, but could you just tell us a little bit about yourself and how this became of such interest that you're specializing in colorectal cancer and you became an oncologist, which is kind of an amazing field?
Sure. Thank you so much for having me. It's my pleasure to be here and chatting with you today. So, I've been interested in oncology, I guess, since medical school, really, because I liked the science behind cancer and cancer development. And then as I went through training, I really enjoyed the special and very intense bond that you have with cancer patients. Because although it can be very difficult, obviously it's also extremely rewarding. And so those two things together really kind of seemed like the perfect fit for me. And then colorectal cancer was really just a function of being a fellow and doing my training at Memorial Sloan Kettering, where we get very, very specialized quite quickly. Just because of the nature of the program. And so I found a wonderful mentor who specialized in colorectal cancer, and I just decided to do research in it and then really fell in love with the patients and the disease and the challenges that it poses. And so that has been kind of my journey. And currently I am an assistant attending at Memorial. I do clinical research, so I see patients, and then I do research mostly in clinical trial development, and then translational work with my colleagues that are in the lab.
Wow, so you're going to be right there when things change. You're right there knowing about them and probably even being the ones to discover it. So since you've been working with patients with colorectal cancer, do you find that they come from referrals or are they savvy enough? Because we know our patients are really educated now. There's a lot of access to information. Do you think they come on their own or is it always through a referral?
I think for us, because we're a cancer center, they come through a referral largely from internists or gastroenterologists. But I think in general, our patients, as you said, especially in New York and the tri-state area, are incredibly savvy and educated and, resourceful. And so they do kind of seek out cancer centers themselves as well.
Right. Now, do you find people when they come to you, they're totally shocked? You must get them at the very beginning. They've just had this diagnosis through probably some kind of screening. But what's the first thing they would expect when they come to your center?
Yeah, it's difficult. Most people are shocked, even if they've been through, sometimes by the time they get to us, because they need a diagnosis to come to a medical oncologist here, even when they have a diagnosis and so they've met with a few physicians, it's always difficult and it's always shocking and challenging. And we find that, a lot of patients, it takes them a couple visits to kind of take everything in just because it is such a difficult, life-changing situation to be in.
Now, who's on your team? When they come to Sloan, you're the attending, and who else is on your team for the patient?
Yeah, so I'm the medical oncology attending, and I work with a nurse one-on-one. So my nurse is with me in all clinics and takes care of all the patients with me. I also have a nurse practitioner who's hugely helpful that I share many patients with, and that is able to cover me as well. And then we have a great support staff. We have research nurses. I have one dedicated research nurse in particular, but if we have, depending on the trials, there are other research nurses that we work with as well. We have research assistants that help run our clinical trials, that do the data management, so they are always there in clinic with us as well and meet many of our patients that go on clinical trials. And then I have a wonderful staff of assistants as well that help to run the office. So it's a big, busy team.
Big team.
Yeah.
Right.
But it's necessary. It's really necessary.
That's so funny. It is a team, and the patient is the center of the team, and we all know that in healthcare. So that's really, really, really nice. And anything I've ever heard about your cancer center has always been very positive. And but do people come and feel guilty? Like, do they feel like? And I'm sure anybody that's diagnosed with cancer, is it something I've done? Is it my father's fault? Is it genetic, or is it something they've done? Like, what are some of the causes of colorectal cancer?
Yeah, so typically, the average age for colorectal cancer is really late 60s, early 70s. And, people often feel that it's something they did or didn't do. We know there are some risk factors, what we call some certain behaviors, smoking, drinking, that can increase the risk of colorectal cancer, dietary changes, obesity in older age or patients in their 60s and 70s. Genetics can certainly play a role as well. A proportion of colorectal cancer is hereditary. Typically, those cases are seen much younger, things like Lynch syndrome or FAP, in which is a hereditary syndrome where patients make many, many polyps that then significantly increase their risk of developing cancer. Those we typically see much younger presentation. But for the average age, it's a common cancer, as you said in the introduction, and the reason that is because our lining of our intestinal tract changes as we get older. Mistakes are made, we form polyps, and then those polyps can develop into cancers. The one big thing that people can do that often, unfortunately, many of our patients don't is undergo screening. And screening is key because the idea is that we know on average people start forming these polyps or these little mistakes in the lining of our intestinal tract at the age of 50. And so the recommendation is to undergo screening so that if there's a polyp that's forming, it can be removed, and then the person's chance of cancer is significantly decreased. And so that is really the one thing where we say, well, yes, maybe that is the one thing you could have done is undergone a screening colonoscopy, at the recommended age.
Wow. You're listening to Your Family's Health on the Voice of Nassau Community College, 90.3 WHPC. My name is Joan Buckley from the Nursing Department here at Nassau Community College, and today we're talking about colorectal cancer with oncologist Dr. Sirsik. I pronounced it correctly. I just want to make sure. But now, that little box, do you ever see the commercial? Now, I'm sure you have. There's a little box, and he wanders around until he finds a pair of glasses outside someone's home. And that's supposed to be a screening that people can do at home. Is it that simple to check? Like you said, one of the things, I could have screened earlier. But what do you think about the home screening?
I think for some patients, the home screening is not a bad idea because, there's a lot of sort of personal reasons why people can't get to the doctor, don't make that appointment, don't follow up. So I think it's convenient, it's easy. Someone can do it themselves, as you said, in the comfort of their home, which is good. And
right.
If it's negative, it's good. However, if it's positive, they then still need a colonoscopy to take a look and see what exactly is going on. Why is there blood in the stool? What is happening? Is there actually cancer, or is there a polyp that's precancerous that needs to be removed? So I'm not opposed to the home screening. I think it's a good start, but it's not the definitive test that we really want people to get, which is a colonoscopy.
I think it's a good awareness piece, and it kind of brings the commonness of it kind of across the board to everybody. But I was wondering just really how effective is it? But if you say it's negative, then we can do it again another time. But if it's positive, it needs follow-up, and that's the same thing, making the time. So do you find that when people have missed that opportunity and they come to you with cancer, do you find they become more willing to make lifestyle changes? Are there any lifestyle changes besides the treatment for the colorectal cancer. Is there anything in our lifestyle that puts us at higher risk of getting colorectal cancer? You mentioned smoking. What else? Genetics. How about
smoking? Yeah, so genetics is not really, something that one can control, but healthy lifestyle is what we generally recommend, which is a healthy diet that we should all be eating regardless of, what we're focusing on. Low in red meat, high in fruits and vegetables, fish, chicken are okay. Exercise is important. We actually have data in people who have had colorectal cancer and are living into survivorship that healthy eating and exercise actually change outcomes. In other words, people live longer and do better if they're able to do that as sort of a preventive measure. And I think those are really the take-home points that we talk about in terms of prevention. Is just a more healthy lifestyle, which, as I said, kind of all of us should be striving to do anyway.
Now, when we see our primary care physicians and we go in and they do ask questions, so what kind of questions would they be asking, and would the person then know that they're talking about the possibility of colorectal cancer? What are some of the signs and symptoms that they may say, oh, has this been going on? What are some of the signs and symptoms of colorectal cancer?
So what we know is it depends on the location of the tumor for a lot of people, but I think the most common symptoms are changes in bowel habits. So people are either constipated or they have a lot of loose stools. Usually it's more towards constipation. If the tumor is located more towards the pelvis, or what we call the left side of the large intestine, the rectum, the people can present with rectal bleeding, actual bleeding, and oftentimes they think, oh, it's a hemorrhoid or it's nothing. But if it's persistent, it's something that should be checked out. Abdominal pain, that's not just a cramp here or there, but that's kind of persistent and doesn't go away, should be checked out. Weight loss, unintentional weight loss, that's usually late in the stage of colorectal cancer, but you'd be surprised how many patients present actually sort of late stage with, well, I've kind of lost 20 to 30 pounds unintentionally. So those are concerning symptoms. Fatigue, so just excessively tired. Often people will say, well, it's my life, I'm busy, but really the sort of excessive fatigue that's often actually due to anemia or low hemoglobin, because there's been sort of this slow oozing from the tumor. And sometimes when it's on the opposite side, on the right side of our intestine, where the stool is still very loose, you don't necessarily see the blood come out, but the person is still slowly losing blood and can present with anemia. Or if they don't know, if they haven't had a blood check, really just fatigue. So those are all important symptoms to get checked out.
That's really very good. And you brought up the fatigue, and that's where I have heard more frequently that's the first identifying factor is someone says, I am so tired, tireder than I've ever been. It doesn't make sense. And like you said, it was anemia. So I know a couple of people that was their first symptom, depending, I guess, on where the tumor was, right? People don't realize how vascular a tumor can be.
That's exactly right. Yeah, and if you don't always necessarily have to see, blood or black blood or blood around the stool. It can be kind of really sort of discreet if it's higher up in the intestinal tract.
Now, let's take a quick break. My name is Joan Buckley from the nursing department here at Nassau Community College, and we are discussing colorectal cancer with Dr. Andrea Sursick, and you are listening to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC, and we'll return in a few minutes.
Whoa, long time no see. It's me, the rock t-shirt in the back of your closet. Dude, remember? You crowd surfed in me, man. But you haven't worn me in like forever. I get it, you're retired, but I still got some rock left in me. So take me to Goodwill, where I can really make a difference.
Your donations to Goodwill create jobs, training programs, and education assistance for people in your community. To find your nearest donation center, go to goodwill.org. Donate stuff, create jobs. A message from Goodwill and the Ad Council.
We now return to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.
Thanks for being with us today. This is Joan Buckley from the Department of Nursing here at Nassau Community College, and today we're talking about colorectal cancer with oncologist Dr. Andrea Sursick, and she's from Memorial Sloan Kettering, which is a cancer center here in the New York area. So now, Dr. Sircik, what is a colonoscopy? Some people may have some misconceptions about what's a colonoscopy. You know, is it a big test? Is it a small test? Does it require prep?
Yeah, so I think that the hardest part about a colonoscopy is the prep. That's what most people complain about. But we've really made an effort to make that the least painful and challenging, or not. I shouldn't say painful because it's not actually painful, but I meant painful in the sense of difficult emotionally for people to go through. So what a colonoscopy is effectively is you need to take a prep so that the bowels move and empty out so that the colon, or the inside of our intestinal tract, is as clean as possible, so that when the endoscopist, which is typically a gastroenterologist, does the procedure, they are able with a camera to see clearly the lining, the inside of the intestinal tract very clearly. So the day before the procedure is when someone usually takes drinks a liquid that basically effectively makes you empty out your intestinal tract, and it's a busy night usually. Should not, again, be painful at all, just kind of busy. And then the next day, the endoscopist, you get some anesthesia, not actually a breathing tube, but just some anesthesia so you fall asleep, don't feel anything. And then the endoscopist inserts a tube with a camera and effectively looks through the entire large intestine for any kind of growths or polyps or any lesions that look concerning. So the inside of our intestine should be nice and smooth. At the age of 50, we start making polyps, and the idea of a colonoscopy is that if there is a polyp, with that same camera, they're able to actually remove the polyp and therefore decrease the chances of that polyp growing into a cancer, because that's really how colorectal cancer is formed. Large majority of them actually start in a polyp. So it is not a difficult procedure. Again, people really worry about it. They're concerned about it, that it's going to be overly invasive or overly painful. It's not at all. The hardest part is usually the prep, but there's really been kind of advances in terms of what to drink or how to prep that your gastroenterologist could review with you that might make that less challenging. And most people find actually once they go through it, they say, oh, that wasn't so bad at all. And then they can at least have the assurance of knowing that either there were no polyps, or if there were any, they're removed. Right. And then they would kind of get a recommendation as to when to repeat it, depending on what the findings were.
Right. No, and I think people just have to understand, even if the prep is a little uncomfortable and awkward, it's a good prep and you get a good result, and then your bowel is nice and clear and the tissue is so visible. I mean, having seen what the photos come, because they do take photos as they go through, I think, and especially of unusual areas, it is absolutely amazing. And you are absolutely right. Everyone I know has gone for one. They don't even, it's nothing. It's not even embarrassing. It's actually very, very, very well presented and everything else. It's just it's not as bad as it sounds like it could be. And the age, aren't you bringing the age down now, where it used to be over 50? What age are they recommending at Memorial Sloan Kettering's cancer centers for screening or colonoscopies to start?
Yeah, so this is now actually it's a research interest of mine, and actually something that we are seeing worldwide actually is an increase in young patients with colorectal cancer. So as I mentioned earlier, typically the average age of a patient with colon cancer is late 60s, early 70s. But what we're seeing now is that in young patients, and these are patients well under the age of 50, even as young as 20, we are seeing this steady rise in the incidence of colorectal cancer. It's still rare, but it's steadily rising since the mid-1990s. And what that has led to actually is kind of a computer modeling of what the incidence is going to be soon. And with that in mind, the idea was that we could lower the colonoscopy age to 45, capture more patients this way, and then improve the outcomes, of patients 45 and older if they're getting screened early. It's a qualified recommendation, so not all insurance companies will cover it. This is a bit of an issue, but we really don't have good hard data like we did when we set the colonoscopy age at 50 to say, okay, it should definitely be 45. But it is something that is absolutely talked about, especially in the colorectal academic community, because we are really seeing more and more younger patients. And it's not just anecdotal. It's not just because we're a referral center. We now have actual hard data that this is happening across the United States. It's happening also, as I mentioned, worldwide and in a large part of Europe, also in Australia, New Zealand, and many, many countries. And so, why that is, we don't know. And so the question is, well, if we screen people younger, then we might also be able to prevent this cancer from developing. But it gets a bit tricky because the age cutoff is challenging because although it's rising, it's still rare.
Right. So, but after your study, hopefully insurance companies will start looking at the overall benefit of not treating someone at 50 or 60 for colon cancer at all. So it just may drop the whole event earlier where they can be screened. Is there a relation between one cancer and another? Like if someone has a particular cancer, say breast cancer, because that's something everybody's familiar with, the outcome is good. And is there a connection?
Not typically.
Okay.
So there are some familial or hereditary predisposing conditions where you might get multiple cancers, but typically there is no link between, let's say, that we know of between, having had breast cancer and then getting colorectal cancer. Some cancers can be, depending on the treatment for one cancer, especially in in kids. Kids have an increased risk for developing secondary cancer sometimes from treatment. But typically, no, not that we know of. And in these patients that are young and presenting with colorectal cancer, we really are not seeing a family history. We're certainly not finding any genetic links. So there's really something else that is causing this really worldwide phenomenon, but we just don't know what that is yet.
Wow. You're listening to Your Family's Health on the Voice of Nassau Community College, 90.3 WHPC. My name is Joan Buckley from the Department of Nursing here at Nassau Community College, and we're talking about colorectal cancer with an oncologist, Dr. Andrea Sursick, who works at Memorial Sloan Kettering with quite an incredible team behind her, and the research being done there just brings one question to my mind then, is how much does it cost? How much could you anticipate if a young person knew they were not covered by insurance? What would be the cost of a colonoscopy, say? If they have a family history, or if they're, just if something's concerning even about their bowel habits.
I believe that if there's something concerning, if there are symptoms, first of all,
insurance,
a really important thing to point out, if anyone, no matter how young, 20s, 30s, is having persistent symptoms, abdominal pain, bleeding, some of the things we talked about,
right,
change in bowel habits that does not go away, isn't related to food poisoning or a brief bout of gastroenteritis, absolutely you should get checked out. See your internist first. Insist on a gastroenterologist appointment if the symptoms are not going away. That's critical. If there are symptoms, insurance, I believe, will cover it. I have not been told, I don't personally do colonoscopies, and but from my patients that I have met, I have not heard, even from my young patients with no family history that obviously were diagnosed through a colonoscopy, I've not been told that they were not reimbursed, that insurance didn't cover it, and then there was now this financial burden of the diagnosis even. So I think if there are symptoms, insurance will cover it. That's not an issue. It's really just for the general screening, in a 35-year-old with no symptoms that we're not sure, or a 40-year-old, let's say. But if someone's having symptoms or a family history, it's typically covered.
Great answer. So now, if someone has colorectal cancer, what can they expect the treatment to be? Is it always surgical, or could it be, just a chemotherapy? Like, is there a standard treatment for colorectal cancer?
So the treatment for colorectal cancer really depends on staging and location. So if we're talking about the colon, which is the entire large intestine until you get right to the pelvis, and then from the pelvis on to the anus, that's called the rectum. So anything in the colon, the first treatment is typically surgery. This is for any stage that is not stage 4 or metastatic. So if we see on colonoscopy there's a mass, and then we do a CAT scan the chest, the abdomen, and pelvis, and say, okay, thankfully there's no disease anywhere else, then the first treatment is surgery. After surgery, the pathologists look at the specimen, and if we see that the tumor, the cells, the cancer cells have spread to the lymph nodes that were surgically removed, or it looks a bit more advanced, then the patient needs chemotherapy. And the idea of chemotherapy at that stage is to get rid of anything microscopic that might still be remaining in the body. If there is no spread to the lymph nodes and it's very, very early stage, stage 1 and some stage 2, then we typically just do surgery and surveillance, and that's it. If the cancer is metastatic, then we would do chemotherapy. And if the cancer is in the rectum, as I mentioned, in the pelvis, then we usually do a combination of chemotherapy with radiation, and surgery.
Is there anything people could do or avoid that would lower their chances or the risk of getting colorectal cancer?
I think healthy lifestyle is key. I would, encourage people to eat well, avoid processed sugars, avoid excessive amounts of red meat, focus on sort of a healthy cardiovascular diet and exercise, quit smoking if you are a smoker, don't start. Heavy alcohol use is also not a good idea. Beyond that, I think the most important point is just to undergo scheduled screening colonoscopy, recommended to start at the age of 50, and for younger patients to really pay attention to symptoms and not to dismiss them. If there are any persistent abdominal symptoms, pain, constipation, change in bowel habits, bleeding, any blood in the stool or rectal bleeding, fatigue and unexpected weight loss, kind of things that continue, definitely seek medical attention and be evaluated by an internist and potentially a gastroenterologist.
I think you've covered a lot of things there. That was an excellent list. But if you had to say one thing to our listening audience that they would remember and take to heart when they noticed a change in their bowel habits or patterns, or someone said they had a change, what would it be? What would you tell them? Would it be something about Memorial Sloan Kettering's Cancer Center, or would it be just some advice from the heart? What would you tell them?
I would say if someone is noticing symptoms that are not going away, to undergo screening or testing either locally with your physician or at Memorial Sloan Kettering. We have a phenomenal gastrointestinal department that can perform routine surveillance colonoscopies as well. If someone is diagnosed with colorectal cancer, we focus obviously on colorectal cancer. We have a specific center dedicated to our young patients under the age of 50 that not only focuses on cancer-related care, but also on the important supportive services that all of our patients need, but especially our young patients, including fertility, social work, psychiatry, and sexual health, that I think are critical to the journey through cancer treatment and into survivorship.
Wow. Is there a website about Memorial Sloan Kettering?
Yes, we have a website. The easiest way is if you Google just young onset colorectal cancer Memorial Sloan Kettering, the website comes up.
That's perfect. Dr. Andrea Sursik, thank you so much for being with us today. This is Joan Buckley from the Nursing Department here at Nassau Community College, and we want to thank you for listening to this week's edition of Your Family's Health.
We'd like to get your feedback on your family's health. Send your comments by emailing them to whpc@ncc.edu. Podcasts of today's show are available on iTunes, Android Podcasts, and Spreaker. This program was produced at the studios of Nassau Community College in cooperation with the Nursing Department. Join us next week for another edition of Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.